Well, welcome everybody. My name is Jack Hallmark. I think we're going to go ahead and get us started. As a reminder, we are recording this, and if you can, please put yourself on mute. That would be appreciated. We plan on saving and editing this into a podcast, and we'll actually share the content as well. As I say, my name is Jack Hallmark. I'm with Optum, and I'm very honored to be a co-chair with Lydia here on the board. Lydia?
Hi everyone, my name is Lydia. I work for the University of California, San Diego. It is a pleasure and an honor for myself and Jack to be with all of you today, and we thank you so much for taking the time to tune in to SOHL's first webinar session.
Some of you in the audience today are representative of SOHL's annual sponsors. In fact, one of our annual sponsors, Catalyst, has joined with SOHL to put this wonderful webinar together. You'll be hearing from them shortly. But before we get into the heart of this afternoon's webinar, we'd like to introduce you to the current Platinum and Gold sponsors, tell you why they're so important to us, why we appreciate them so much. It's very simple. We can't do what we do without the support of our sponsors. As you're probably aware, SOHL's members are both aspiring and established healthcare leaders. What I've come to learn since coming on the board is that SOHL is a very energetic and ambitious chapter with a lot of dedicated people. Until the pandemic, we put on about 10 programs or events and networking opportunities annually for our members and for the community. An executive program, a mentoring program, a program to help prepare aspiring healthcare leaders prepare for ACH's fellowship exam. All of this activity is capped with our annual conference. What you may not be aware of is that a significant portion of our revenue comes from sponsorship. So sponsorship supports us truly do what we can do. So a special thanks to all of our sponsors. Here we have Catalyst, as we stated earlier. Debbie and Michelle are coming to us to help us put this event on. Scripps, Sharp, SOHL, Hospital Association of San Diego Imperial Counties, UC San Diego Extension, UC San Diego Health Systems, University of Phoenix, Kaiser Permanente, AMN Healthcare, Tri-City Medical, and our latest sponsor joining us, the Indian Health Council. For today, in terms of our agenda, I just went over in terms of what we were covering and going to dive into a little bit about American College Healthcare Executives local chapter, SOHL. And Debbie is going to provide an overview of where we're at within the San Diego region, and then we're going to kick it off to our panelist presentation, and we set some time aside for Q&A at the very end. So from a chapter perspective, we are one of 80 chapters on a national basis, your local connections to the American College of Healthcare Executives, and serve as a vital link to healthcare professionals and health administration students. A welcoming place where you can connect with other healthcare leaders in a professional, friendly, and supportive environment. Close to home opportunities for learning and networking. You'll also have access to education programs that qualify for Category 1 and 2 ACHE education credits. We provide programs and resources for niche communities, including students, early careers, emerging senior executives, and CEOs. You are automatically enrolled in your local chapter when you join ACHE. If you are currently a member of ACH, you'll find out more about your local chapter by signing in to the chapter area of My ACHE. As an ACH member, you may also opt into contact list of up to 5 additional chapters in our region, and those chapters, at no cost, will then send you notices and announcements about events that are coming up. This is just an example of the awards as a local chapter, what we're doing to advance and move the actual chapter along. Lydia?
So one of our chapter goals is to enrich your professional development and add value to your ACHE membership by providing providing networking and volunteer opportunities, education programs, and assisting with advancement to the ACHE Fellow. On the next slide, we show a list of programs and events that we typically offer throughout the year, but due to the current situation, we are shifting and looking for ways on how we can provide these services and programs to you. On the next slide, we have a program called the Advancement Study Group that assists you on your path to earning your FACHE credentials. This program is designed to help members prepare for the FACHE exam. They provide weekly lectures, are presented by subject matter experts, and review topics covered in the exam. So this slide shows the SOHL's 2020 Board of Directors. And on the next slide, if you're not currently a member of ACHE or SOHL and want to join and get involved, this is how you enroll in it. Once you enroll as an ACHE member, you're automatically placed in a local chapter based on your business address or place of residence. So Jack will be talking about other ways on how you can stay connected with SOHL.
There's definitely several avenues. But here are a couple of different avenues to actually stay connected with us as a resource from a programming perspective. And I'd like to also recognize our county partnership that we have here in San Diego. Very fortunate to be a part of this group.
Thank you, Jack. So with that, it is our pleasure to introduce our moderator, Debbie Jacobs. Debbie Jacobs is the director of the West Region for Catalyst, which is a healthcare advisory firm focusing on providing strategy, operations, facilities planning, and activation planning services to hospitals and healthcare organizations. Debbie's 30 years experience as a leader in healthcare has given her the knowledge and insight to bring innovative and creative solutions to her clients. During the past 2 months, Debbie has focused her efforts on helping clients navigate the COVID-19 pandemic and plan effective strategies to manage immediate challenges, as well as plan for long-term facility and operational responses. So, kick it off to you, Debbie.
Well, thank you. Well, good afternoon, and thank you for taking the time to join the webinar from wherever you may be working this afternoon. Some of us may be back in offices today, given some of the changes in the orders. Catalyst is very excited to sponsor today's webinar in partnership with the San Diego Organization of Healthcare Leaders. And our goal for today is to really bring the discussion down to the local level. I know we have all been inundated with opportunities to participate in webinars, and they've been very helpful. The state and national statistics are directionally informative, but really less relevant when it comes to the impact of the coronavirus on our personal and professional lives. So today it's our hope that these conversations will give you a better idea of what's happening locally. You'll be able to understand some of the priorities and challenges our local healthcare leaders are experiencing today. So a lot of things are happening in our community, and this is a very timely call, and you'll be able to understand some of the things that have changed since yesterday. We'll also be sharing with you some of the operational, clinical, and facility efforts that are being undertaken by organizations across the country to address today's and tomorrow's challenges. Next. So when we were coming up with the title for this webinar several weeks ago, the data was showing San Diego to be, excuse me, well on the other side of their curve, hence the name On the Other Side of the Curve. But as you can see from the graph, which is showing new cases per day, we're flattening and maybe starting to come down, but still a lot of fluctuation in the day-to-day cases, and in fact, recently are experiencing a bit of an uptick. But with that, I'll also have to say that it's true that our city and county have been extremely fortunate in terms of the total number of cases and deaths that we have seen, but we must continue to stay vigilant. Next. These next couple of graphs are from the New York Times, and if you go and you look at the first one, it shows that San Diego, our death rates are doubling every 25 days, which is an independent number. It's hard to make meaning of, but 4 days before this, we were about at 20 days. So again, this is a snapshot in time. Right now, we're doubling our rates or increasing that time frame. But again, we just need to watch every day what's going on. Next. This chart is from the County of San Diego Emergency Operations Center. And what it shows is that we've been increasing our testing capacity on a daily basis. And as we've been doing that, we're seeing that the positivity rate for COVID-19 is coming down. And right now it shows for a county that we're around between 4 and 5%, which is a good number, but again, you have to look at what's happening down on the ground and at the community level. And I think our healthcare leaders are going to share some more insights into these numbers, because we need to be careful in that sometimes they are presented in an average and kind of don't present what's actually happening to our individual residents. Next. So this slide has a lot going on, but basically what it shows is that our coronavirus census has been somewhat level, although we've been seeing a recent increase, and we're having somewhere around 400 patients per day in the county and the hospitals. And you see that right now our bed capacity is above what we have in terms of patients occupying beds, so that's valuable. But again, as things change on a daily basis and we have to prepare for changes and surges, we need to be constantly watching the number of beds we have available relative to where our census for COVID and non-COVID patients are going. So with that overview, which I'm sure our panelists will shed more light on, next please. So our panelists will talk to you about the day-to-day challenges they are facing, as well as what they're thinking about as they think about the next few weeks, months, and year ahead. And again, while the San Diego data I showed you is very helpful in understanding what's generally going on, our panelists are going to talk to you about what their experience on the ground is today. There's a chat box that's been opened, so please feel free to enter questions into that chat box, and we will get to as many of them as we can at the end of our presentation. So let me introduce our first panelist, Chris Van Gorder, who's President and CEO of Scripps Health. Mr. Van Gorder is responsible for all activities at the $3.2 billion integrated healthcare delivery system and has been leading Scripps for the past 20 years. Mr. Van Gorder serves as Scripps COVID-19 Incident Commander for the system and leads the Scripps Corporate Command Center. Dr. Ghazala Sharif is Chief Medical Officer of Scripps Health and works side by side with Mr. Van Gorder. Dr. Sharif oversees the Clinical Excellence and Experience Department and is responsible for running Scripps Health COVID-19 Command Center. Demetrius Alexio is President and CEO of the Hospital Association of San Diego and Imperial Counties, and he has served in this capacity for over 5 years. As President and CEO, Mr. Alexio provides leadership, representation, and advocacy on behalf of over 38 hospitals and health systems in this 2-county region. During the COVID-19 pandemic, the Hospital Association has acted as convener of discussions with its member hospitals, the County of San Diego, and elected officials. Michelle Mader is President of Catalyst, a national healthcare consultancy company. During our national COVID-19 crisis, Ms. Mader has leveraged Catalyst's interactive business intelligence tools to assist healthcare organizations to optimize their existing capacity, reprioritize their CapEx, and reevaluate the feasibility and financial ramifications of their various short and long-range strategic initiatives. So with those introductions, I will now turn the floor over to Chris Van Gorder and Dr. Sharif.
Hi, good afternoon, everybody, and thank you for joining us in this webinar. I've had the pleasure of being a member of the American College of Healthcare Executives since I was a student many years ago up in the LA area, and my CEO was a regent with ACHE, and over the years I had a chance to be on the Board of Governors and serve as chairman of the American College of Healthcare Executives back in 2010. So for all of you supporting ACHE and our local chapter here, thank you very much. I'm not going to spend a lot of time. In fact, our presentation is going to probably dramatically change from what we had planned because COVID is a constantly moving issue, and we're actually at a very unique point right now. But our healthcare system's regional with 5 hospital campuses and, I don't know, somewhere now around 35 or so ambulatory sites. We have a relationship with Pioneers Hospital out in Imperial County, and I think we'll just go to the next slide. As mentioned in the introduction, a $3.2 billion healthcare system, about 15,000, getting closer to 16,000 employees, and about 3,000 physicians. As you all know, we can't employ physicians in the state of California, so we have 1,000 physicians roughly in our medical foundations and about 2,000 independent practitioners. Next slide. When this whole thing started, we're actually in what we call operational period 97. We actually activated our emergency operations center when we were watching COVID spread through China and starting through Europe. Since we received 2 aircraft of U.S. citizens and dependents at Miramar between UCSD and Scripps Mercy Hospital, we actually took care of a number of those patients. So we were gearing up for COVID-19. It wasn't even COVID-19 at the time, quite a long time ago. I was actually involved in the establishment of the original Hospital Emergency Incident Command Center in Orange County. I was a nurse with the Orange County Health Department, a nurse at Huntington Beach Hospital, and I was a vice president at Anaheim Memorial Hospital when we watched Orange County develop the Incident Command System, which is now used worldwide, and we developed the Hospital Emergency Incident Command System to model that. It was ultimately adopted by the state of California and now is a national standard. So we're pretty darn familiar with the operations of the Hospital Emergency Incident Command Center, and we've been operating it. Early on, we developed visitor restrictions. I got an email when COVID was still in China from one of my doctors suggesting we send our N95 masks to help them in China. And I immediately said absolutely unequivocally no, that the way this is going to go is N95 mask may be the #1 black market item in the entire world, which is exactly what ultimately happened. And so we put tight restrictions on our supplies very early on and wanted to make sure that they were all used appropriately. Made our connections with the local county in particular, and I've been working with the county's Emergency Operations Center literally on a daily basis ever since, and very closely with Demetrius, with the Healthcare Association, Hospital Association as well, literally on a daily basis as well. You'll see there's probably more collaboration right now. Demetrius will speak to that between the hospitals who normally compete and vigorously compete with each other, but in times of disaster and emergencies, we collaborate a lot as well. It's never perfect, but it's much better than it usually is. And I can tell you my counterpart right now is Dan Dan Gross over at Sharp, who was retiring, but ultimately got kept on to manage the COVID experience. And since Sharp has been the busiest with COVID patients, I think they hit a peak of about 135 patients, and they're dipping down a little bit right now, but that may all change very quickly here because of Imperial County and Baja. We are actually spiking today. We just went up 7 patients overnight, and we're anticipating receiving patients potentially from Imperial County as well. And I know I saw some of our colleagues, I think, calling in from Imperial County today. So, as we originally got this going, information was critical. We established a nurse triage line and actually developed triage car testing, basically drive-up lab testing outside of our facilities to make it safer for our own employees and safer for the individuals getting tested. And at one point, we had 60 nurses handling more than 2,000 phone calls every day. That has dipped down dramatically now because they have 211 and other organizations have geared up, but we still have our nurse call and we still do car testing to this day. Let's go to the next slide. Thank you. This is planning for what's coming. You're just going to look down, and what I'm going to do now is talk to you a little bit about what's really happening. San Diego worked very hard. In fact, I sent a memo to the county and to several of my colleagues several months ago now, suggesting that we shut down San Diego. The county listened. I think they were already in the planning, so I'm not taking credit for anything. But they called a meeting the next day with all of the hospital chief executives and healthcare system CEOs and the leadership, the public health leadership, and some of the county board of supervisors actually at a meeting the following day where I laid out about 7 different recommendations, and that was used actually as an agenda for the meeting. And the following day we implemented restrictions, and that has been successful in doing what we wanted it to do, which is flatten the curve. Our data scientists are analyzing on a regular basis and indicate that we have been, as a county, roughly 60% successful with our sheltering in place, social distancing, and the work that we've done literally by shutting businesses down. That means that our projections are that we will actually peak somewhere in the area of June, July. We'd see constant increases in cases during that period of time, but since all hospitals stopped their elective procedures, we opened up at least 50% of our capacity. But when you look at that capacity line you saw in the earlier chart that shows how much capacity we have, that's total bed capacity. That doesn't indicate how many intensive care unit beds or negative pressure isolation rooms. And so we would actually peak long before we ever filled up 80% of all of our hospital beds in this community. So that's something we have to keep an eye on. In addition, testing has been a big indicator. It's one of the president, governor's check marks for reopening businesses. And for most of the time period we've been doing testing, we were running in the area of 6 to 7% positives. That has, in fact, dipped to around 4%, but partially because we're testing so many more people now. If you were actually to look at South Bay and Sharp, Chula Vista, Scripps Chula Vista hospitals closest to the border, we're still running 18% positives, and those have spiked as high as 29% positives. So when you're looking at our community, you cannot just look at the total community. You have to look at segments of the community that may have issues as well. And we raised early a concern around Baja. We know that Baja started doing their social distancing and restrictions much later than we did. They are, in fact, seeing a spike in cases. Their 4 public hospitals have been very challenged. Lack of PPE, they've actually had to close some floors down because they didn't have staff to staff it. And if you go east to Mexicali, as of yesterday, both of the hospitals out there, I'm told, are on basically bypass. They're both full, and that's obviously impacting Imperial County. And I'm told that over the last 3 days, they've seen a 37% increase in their cases. And we know, we just got a notice a few minutes ago that UCSD just got 3 cases from Imperial County, and we fully anticipate getting some from Pioneers Hospital probably as well today. So when we look at our state and we look at our county, we have to consider Imperial County and, of course, Baja. We have normally around 90,000 vehicles a day crossing. That's been reduced today. It was 68,000 vehicles. But these are U.S. citizens and often many of them are employees coming into San Diego. We don't want to close down the border, but I think we have to be concerned that some of what's happening in Baja is going to impact San Diego County. In fact, we now ask our patients coming to Chula Vista if they have crossed the border within the previous week, and those numbers are running 39%. The patients we're seeing in Chula Vista had crossed the border within the last week. We know that there's at least 1,000 U.S. servicemen that live in Baja, Mexico, and we have employees as well crossing the border. So that's a risk area that we have to consider as we're planning on how we're going to ultimately manage this. I want to turn this now over to Dr. Sharif. She can talk to you a little bit about how all the chief medical officers have been working together and how we manage our corporate command center and any other issues she'd like to share.
All right. Well, good afternoon, everybody. It's been a big learning curve, as you can imagine. One of the best things that's come out of this is our regional chief medical officer meeting. I host a meeting every Wednesday morning, and it's just the CMOs across the region. There's nobody else on the line with us, and very candid conversations. We're sharing more protocols and procedures than probably we would have ever before. And it's very comfortable, very candid, and as I mentioned, that's one of the best things that's come out of this. Chris had mentioned some of the innovations that staff has been doing. We actually just created a testing booth. It's plexiglass. It gives our staff an extra layer of protection, so they stand behind this plexiglass booth and they can stick their hands out and do mass testing for COVID without having to be exposed. All they need is a surgical mask and gloves, basically, and one isolation gown for the day. So we're trying new ways to protect PPE. PPE has been a big topic, but you will be surprised at things that we're actually running out of. It's not so much N95s, because we've done a great job of reusing them, and we actually have started reprocessing the masks. We're not using the reprocessed ones yet, but we have them in supply. It's actually disinfectants. We're actually being very creative on making our own bleach wipes, which we never thought we'd have to do. And the other thing that we're having a shortage of is some ventilation supplies that we need to even open up our operating rooms. Those are the HEPA filters. So things that we did not anticipate, we are running short on, and so that's going to slow up our ramp up. As you can see on the slide here, on the very bottom, we're calling it a phased return to services. We can't open everything up as much as the surgeons want to and open up everything on elective surgeries, just because we do have to monitor the supplies and testing. Those are rate limiters, and so we're calling it time-critical patients, and we're doing everything on a rolling 2-week basis, and really constantly day-to-day managing supplies. We were supposed to get a shipment of ventilatory supplies in actually this week, and it did not come in, and so now we've got to go back and redo everything all over again. And so the idea behind time-critical is what procedures need to be done over the next 2 weeks that patients have been waiting for. And some simple examples are a patient who's waiting for hip surgery, and he has now dislocated his hip 3 times in the last week and a half. That's not elective anymore. It really is time critical. There's a lot of our elderly patients have been waiting for cataract surgeries. Now they can't pass their DMV test, and so those are becoming more and more critical as well over the next two weeks. So that's actually how we've been planning things. And so it's a daily change. And so as far as Chris mentioned, how we run the central command center, we are actually working on protocols throughout the system to save PPE, how to manage critical patients, the remdesivir meds that were just delivered, working on those protocols as well. And so every day is a new day when it comes to COVID, and things change literally hour to hour. And so managing all of that across our 5 hospitals, and we have, as Chris mentioned, ambulatory clinics that we have to all keep in balance. So it's literally a night and day job, but it's been fun to see the collaboration even amongst our internal physician partnerships. That's probably the most rewarding part for me.
I guess maybe 2 final comments during our little segment here is number one, there are, clearly heroes in healthcare today, and it's nice to see our nurses and our doctors and our respiratory therapists all recognized with flybys, and our residents getting out and hitting their pots and pans at 8 o'clock in the evening, et cetera. But there are people behind the scenes. Our supply chain people have been unbelievable in being able to source things when other organizations are getting forgeries, counterfeit items. Our people have been able to screen that. The community has been extraordinarily generous with their donations. Our laboratory staff has been unbelievable in bringing on new platforms so that we can increase our internal and external testing on a regular basis. So, everybody behind the scenes is as much a hero as the people who are obviously taking care of our COVID and other patients. The other thing I will just end with is saying is well, a lot of people, I think we're getting back to normal, and it's good to see some of our businesses open again. I think this is one of the more dangerous time periods. We've been successful getting 60% success with our social distancing and based on the regulations we currently have. As those regulations ease, and I can see it already, people are not socially distancing, they're not wearing masks. One of the things we're hearing is the reason there's a spike potentially in Imperial County is because of Mother's Day and large gatherings that took place over the Mother's Day holiday. We risk that very same thing here in San Diego if we either open too fast or we open too fast and the businesses that open don't adhere to the strict requirements. Till Gawande, if you haven't read it, put out a very good article recently that said that the formula for success here is going to be screening, masking, social distancing, and tracing. And he says, and just like any kind of situation, if you have one of those elements are missing, then you're not going to be able to protect your business or your community. And we're going to have to do that even more so as we reopen again, which is a good thing, but there's a high risk with that. And that high risk, of course, is that we're going to see pockets of infection, maybe surges, maybe bad surges, and of course that could end up impacting the healthcare delivery system that we have been successful protecting thus far because of flattening the curve. And with that, that's my alarm that says I've talked for 15 minutes, and I'm going to stop now, and we'll carry on during the Q&A session.
We both talk really fast. Hopefully you were able to keep up with us. That was the decaf version. All right, back to you, Jack and Lydia.
Okay. Demetrius, are you up?
Sure. Thank you, everyone. Again, appreciate SOHL pulling this together and all of you taking the time to hear our thoughts today. These are interesting times, and I think Lydia or somebody might have said at the beginning, I probably would just toss out my slide deck at this point and just have a conversation. But let me run through these pretty quickly. Go ahead and next slide, please. So this just gives you a layout. We're fortunate here in San Diego to represent two counties, blessed to work with great leaders like Chris, and I'm not just saying that, I mean, really do mean that we are fortunate to have some great leadership down here. And yes, it's competitive to the point that Chris said, but there's times like this where that goes out the window and you see the true heart and spirit of folks and their ability to work together. Our membership is pretty diverse. 100% of hospitals in the two-county region are members, and that does include both naval facilities and the VA. Next slide, please. So some of the items on the agenda asked us to talk about most pressing needs and challenges. And to me, obviously, we're dealing with a pandemic, but what will follow and what is starting to be talked about is the economics, because these are creating some challenging times. This slide that you're looking at is obviously pre-COVID, not the number of hospitals, but as you look at economic output, even the ED visits. So much of that will look quite different as we move out a quarter or a year from now. But what is clear is that even at a statewide level, due to hospitals stepping up, as the county asked and as the governor asked, and reducing capacity, meaning those who are in beds, stopping some of the elective procedures and putting off some deferred maintenance, so to speak, facilities have been losing significant amounts of dollars to stay at the ready for a surge. And we've seen some spikes, but not quite what was anticipated. And even in the short-term estimates as a statewide, hospitals have lost over $10 billion. And these have significant impacts in terms of the future. And that's where you're seeing talk of legislation, talk of support, both at the federal and state level. Next slide, please. And this also spills over into the workforce. In normal times, again, this slide goes to pre-COVID. Here in San Diego County alone, I mean, you're talking over 70,000 jobs, and not just jobs, but good paying jobs. So you're talking, over $4 billion in salaries, wages, and benefits. But again, as a reminder, since the orders came out and as facilities flex down and had decreased volumes, it does create some challenges on the workforce, and you're seeing and heard some of the stories as it relates to flexing and furloughs. I mean, these are very real challenges that all of our systems are dealing with on different levels. And I do believe, though, as we do move forward with the non-emergent and sort of deferred procedures that were put off, we're hoping that the unemployment and the furloughs of healthcare workers will lessen. But in the immediate term, we are going to continue to see lower volumes than normal for a lot of the concerns that Chris even referenced as it relates to the supply chain, whether N95s and PPEs, that until you have stability there, it's hard to start to ramp up to where you'd be in normal times. What's also going to be interesting as we see a return to baseline is it's going to make some difficult decisions. Now some of the things that we're seeing is an increase in telemedicine. And we talked about that over the years, how important telemedicine is. But, Chris and Ghazala could speak to this. I know I've seen numbers from Sharp. It's a significant shift from where we've been historically. So as things start to open up in the future, I think you could see some shift to new types of jobs, more in the IT, telemedicine, teleworking sort of field, as well as screeners as we look at the T3 and start to ramp up testing. We need to be able to trace and screen all of those things. So I think what you're going to see is a change in the workforce in the future as well as we come out of this. Next slide, please. And so, as health systems collectively are turning up the dimmer switch, the challenges remain. PPEs, testing supplies. Childcare has been an area that locally we've been advocating for because we've heard that from our hospitals. I can say that sort of self-servingly as a parent of 3 children, but our nurses, our staff, there are those workforce who do have kids, and as the schools closed, it also creates some challenges from a workforce perspective in terms of where they go. Obviously, on the priority side, it is taking care of the deferred care, those procedures that were put off. In some cases, could be cancer surgeries, could be some other things that help with mobility, bringing those back. But at the same time, there's been a clear directive, both in the conversations locally as well as at the state level, about maintaining some sort of capacity. That remains to be seen where we land on how much. I know initially the governor talked about 35%. We've had conversations on, is that the right number? Because one of the things that is clear is that hospitals are agile, meaning they're able to shut things down pretty quickly. Where the challenge comes in is it's harder to ramp back up again and reopen things in the future. But from the concern side, what I would say is, we're not through this. We do have an increasing number of hospitalizations as the economy reopens. We'll see more positive cases. One of the other things that hasn't been talked about as much as well is as unemployment has gone up. I think I saw a number from Sandag that San Diego County is up to like 26% unemployment. I know in Imperial County pre-COVID, they were about 25, 26% unemployment. And I've heard that they're pushing 40 to 50% unemployment now. That causes a shift in coverage in insurance. And in San Diego County alone, since March, there's been 21,000 folks who have been added to the Medi-Cal rolls. Those have a financial impact on hospitals that has a coverage impact on the community. So a lot of that remains to be seen. And, again, some of the concerns you heard from Chris as well is as we look at carefully reopening the economy, we are going to see a surge. And it's important to keep in mind that flu season will come back around. So you layer a full flu season with potential spikes, and it does create some capacity challenges as well. Next slide, please. And, I can't reiterate this point enough, and I know Chris said this as well. What we've seen thus far in San Diego County does not necessarily reflect where it's been at the state, whereas the state's seen a lot more flattening. I would say we've seen a flattening of the curve. We definitely have not flattened out our curve. And whether that's what Chris shared, he's gone up 7 COVID hospitalizations today. Imperial County with their surge, I want to say one of the hospitals added 14, the other added another 7 or 8, and that's since yesterday. And so the 2 hospitals combined out there have over 80 hospitalizations. Those create some significant challenges. We're definitely not through it, and we're unique in San Diego. I know we say that about all sorts of things, but having a border situation with the cases down in both Baja, from the TJ side to the Mexicali side over in Imperial County create some concerns. And then the concerns with, as Imperial County goes, so does San Diego, because as they go on diversion, things do start to spill over. So these are things, as an association, we're working with our hospitals out there, with our electeds, and with the state to ensure that the resources are needed out there are available, because as they get overwhelmed, it does have an effect as it moves into San Diego County. Next slide, please. And this just gives you, again, reiterates the same point of that we are slowing down, but we definitely haven't flattened, and it's different days, different scenarios. Some days we're up, some days we're down, but we're definitely not on a downward trajectory at this point. Next slide, please. And this is data that we've been tracking and sending out to our hospitals daily just to raise awareness of the whole region. And unfortunately, what you're seeing is a climbing still in Imperial County. So it just reiterates that we do have to be cautious. I know everyone wants to open up things quickly. I think we all want to get back to our normal lives, but just know that we're not quite there yet. And if we do this incorrectly, some of those spikes that you're seeing in Imperial County could easily move into San Diego County And, with 3.4 million people in San Diego County, those spikes would be very taxing on our healthcare system. Next slide. And I know we talked a little bit about lab testing. I'd say this is another area where we've been heavily involved. Scripps early on stepped up and brought lab testing in-house, and purchased a lot of equipment to be able to gain capacity. Our other hospitals have taken similar actions. And this is, again, where we're a little unique down here in San Diego, in that you don't have a public health system like what you have, take LA County, where they have, I believe, 5 county hospitals. We don't have that down here. So therefore, the resources that public health has look quite differently. And that's where we've had a number of conversations with the county as these things have ramped up, that our hospitals have stepped up and are willing to do so. But we need to continue to work collaboratively as the statewide goals sit out there, as the county goals sit out there, that for us to be able to reach the testing numbers that are needed to continue to move, there's got to be some give and take from the county side, from the hospital side. So this just gives you some stats, and I know these are a little dated since I sent these in. I think the last week we're probably averaging, the last couple of days at least, over 4,000 tests per day. So things are trending in the right direction. But just remember, even testing alone, and this is something I've heard from Ghazala and others from our clinical folks, it's a point in time. So as much as we want to make testing the be-all, end-all, a negative test today does not mean a negative test tomorrow. It just means a negative test at that given moment. So that doesn't mean you can get a negative test and go back to all kinds of crazy behaviors, because that will lead to more positive tests and, unfortunately, more hospitalizations and, unfortunately, more negative outcomes, as well, as we're still figuring out this virus. Last slide, I believe, and then I'll hand this over. So in terms of the short-term outlook, and this is also a key point, because I know I did a SANDAG presentation earlier or late last week, and even as I saw the notes here, we talk about these things like, what do you see in the next 3 to 6 months? And it's important to know that COVID, while it came quickly, is not going to leave quickly. So there really isn't a 3-month outlook. We're going to be dealing with this for quite some time until we have a vaccine, until we have treatments, that this is sort of the new normal in the short term. So what I would sort of wrap this up with is that hospitalizations are not yet decreasing. The situation at the border does continue to evolve. Imperial County does have a disproportionately high number of COVID cases. In fact, I believe they have the highest number per 100,000 in the state. We do expect a resurgence of COVID cases in the fall, and that's complicated with flu season. We do need widespread testing to further understand a number of things. One being, what does this really look like? What do rates really spell out? Until we have more testing, it's going to be hard to figure some of that out. But all of this is wrapped up in the economic pressures on hospitals are real. They will continue in the short term, and we have to figure out some of those challenges, because as our hospitals stepped up to provide capacity to be there as a resource, they're needing help as well to continue to be there in the future. So with that, happy to take any questions after we're all done, but that concludes my presentation.
Thank you very much, Demetrius. That was an excellent summary slide of where things are today. So with that, Michelle Mader, the president of Catalyst, will talk about some of what we've been experiencing as we work with our clients across the country who are at all different phases of the curve.
Absolutely. Thank you, Debbie, and thank you and welcome this afternoon. You've heard both from, my counter panelists this afternoon about sort of what's happening in Southern California and in particularly in the San Diego County. We are seeing some of this with our local clients in California as well, and I'm going to go through these pretty quickly. I know we're running short in time. We've got about 15 minutes or so. We want to do some Q&A, so I'm going to fly through these a little bit. I'm happy to answer any questions afterwards. Some of this has already been touched upon through other discussions, other or maybe a little bit more specific to things that we're seeing actually people do. One is that as offices are opening in general, the economic offices, professional office buildings, we are seeing increased safety protocols and screening for associates re-entering the workforce. And so again, that is putting a strain on some of the supply chain issues, is that we're now having masks and hand sanitizers at every office, on every cube across the country in general, but particularly in Southern California as they start to look to reopen. So we'll continue to see that. We are looking at redeployment of internal personnel. So as hospitals have shifted people from clinics into hospitals or have moved people from ambulatory locations that have not been doing elective surgeries into other areas of the health system, reshuffling them back as we try to start that's going to take time, right? So it's not an overnight phenomenon that happens where all of a sudden we've got everything back to normal again. So that's going to, the redeployment of internal personnel, both within healthcare as well as externally, and our partners and our county partners, et cetera, is going to take some time. The other issue, which I think has been touched upon briefly, is just the amount of workforce anxiety and the level of unemployment that is happening. I think we're adding hundreds, if not hundreds of thousands of unemployment daily across the industry, both inside of healthcare and outside, and that we're looking at a slower economic reentry in general. And as states are different in their phases, and as they're different in opening up various levels of economic restability, we are going to see that kind of move forward. So next. Also in the short term, some of the things, and you heard this talked about on the PPE and on the supply chain side, not just with masks and N95s, but also in a whole bunch of other areas. We are seeing supply chain having a really hard time keeping up. If you haven't noticed, we are having various meat and poultry shortages. It's not because we have less cows or less chickens. It's mostly because we can't seem to get the manufacturing up and running due to COVID issues, as well as the supply chains and trucks on the road. So we are seeing that not only with supplies within healthcare, but also on the medical equipment. So getting ventilators, getting IV poles, just basic sets of equipment that we were normally able to centralize and to staff out to various locations, getting those redeployment. And we have some clients who are even taking them from ambulatory sites and moving them into acute sites just because the shortage is pretty severe. We are also looking at reevaluation of medical construction. So as you guys have known, San Diego County has had a lot of construction over the years, a lot of, several new hospitals that have been built, a lot of capacity. We are starting to see that be reevaluated to what was mentioned earlier on just the financial pressures and the economic pressures within the industry, but also within the economy. You can expect that those will not only be reevaluated. Most organizations have put all their CapEx on hold. They're looking at the highest, the biggest bang for their buck ROI returns, but you will continue to see some of that, especially as we look at the financial constraints kind of moving forward. So for those of you who are on the phone call who are in the support areas within the industry who are in the middle of all of this, we're seeing it across the country, not only in southern San Diego, but also in other locations as well. So next slide. Really quickly, there are two things that we're seeing locally there that I think that is an increased interest. One is increasing provider M&A. We're looking at a lot of independence. You talk about not being able to be employed by health systems in California. We're looking at a lot of independents who are struggling. They're struggling to keep their practices open. They're struggling with investing in technological platforms for telehealth, and they're struggling in just keeping up with day-to-day supplies and or payroll. And so we are seeing that the increased M&A that is happening. In fact, most of the financial consultants and our peers who we work with a lot, their biggest areas right now is M&A, both at the health system level as well as the individual practice level. So we will continue to see that, and tracking that's going to be important as it relates to referrals. And then also there's a really small timeline. We are collaborating together right now, and I think that's all great, but we still live in a highly competitive environment, and we are seeing some out migration. For patients who work in one area of Southern California but live in a separate area, there's a narrow timeline in which health systems and providers are able to close that out-migration gap that has occurred because people are at home, right? They are not going into the workplace. They are not commuting into the downtown area. They're staying in the suburbs. And so our ability to keep them in the suburbs and to be able to provide for them from an out-migration perspective is key. And it's key not only to making sure that those patients are very loyal to our systems and to our referrals, but also making sure that we're able to take care of them in their home and in their home communities, and not force them to commute if we don't have to. Next slide. And again, I'm talking really fast, so again, I'm happy to answer any questions that you might have. So looking sort of past the next 2 to 3 quarters, even towards the end of the year, what we might expect longer term, and longer term could be the next 2 years, it could be the next 5 years. Most of the national projections right now, and even the localized California ones that we've been doing most recently, have future demand estimates in volume less than pre-COVID-19 levels. meaning that the change, it's going to be not only a mix of volume, but also the mix of, case mix, as well as severity and acuity levels. Where telehealth is going to have a tremendous impact. It's expected, it already is, particularly in the ambulatory environment, as we look at what that might be. So as we look at estimates for the future, that might be less than we had going into this in the spring of 2020, and that the case mix might be a whole lot different. How we plan for those patients, how we handle the financials of those, what their care protocols look like, all of that's kind of going to be into play and changing. The other thing we're seeing substantially, and this is on the cost reduction side, is the rationalization of services. So as providers do more M&A, as we look at underutilization of key areas, as we look at how to manage COVID versus non-COVID patients in co-locations in facilities and things like that, do we need an MRI everywhere? Do we need phlebotomy everywhere? Can we staff it? Do we have enough supplies for it? Can we handle the CapEx or the overhead expense of the facilities? So there is a renewed focus on rationing of services from a cost standpoint. Next slide. Longer term, what we're seeing that has in models that look out 2 to 3 years in demand, and that's really hard right now, as you can imagine, that really has a tremendous amount of dependency around telehealth. So we call this telehealth grand or sustained entrance, right? Telehealth has been around for a long time, and people have a lot of looking at different platforms that they have invested in. Some have invested heavily, others have been invested almost none. And so as we look at telehealth sustained entrance and viability, the long term, we expect more care to be delivered at home. So there was an article that was published from a national journal this morning that just talked about, could we do PT, physical therapy, long term at home, and what that would mean for the patient and for caregivers and for the care model in general. We typically pair PT with a lot of specialty and a lot of primary care to keep patients close to home and to keep that care centralized. So as we look at what telehealth is going to do, it's not only going to impact our financials, but also our volumes, our facilities, right? Our traditional investments we normally look at. It has the potential to completely change the care delivery model as we move forward. So it's something that we're keeping a really close eye on, that as we look toward future investments or how we handle things post the curve, right? Once we kind of get COVID stabilized or we manage the potential surge in the fall, what does that look like on the other side? And even how are we delivering care right now to patients who are not COVID patients, right? Who just need care in general. Next slide. So to kind of wrap this up really quickly, in the future, we are anticipating a couple other things to happen, and particularly in California, based on your historical regulatory controls. One is around isolation capabilities. We had this with the seismic 10, 15 years ago. We expect this to happen around the isolation, more negative pressure, more isolation, being able to provide quick mobile solutions, as well as increased security and access protocols. Those are in place right now in our facilities, but we're anticipating them being in place for a while, longer than the next year, as we look to increase access and who's infectious versus non-infectious, who's exposed, who's not exposed, who gets into areas that they typically have been able to get into that we may be rethinking about now. So next slide. And then lastly, the last couple of ones is the future of ambulatory care. That's been a hot discussion right now, particularly as we look at some of the major health systems in Southern California and LA area. And we're calling these asset light models. There is significant capacity right now. Most of it's because we're deferring care or patients are not coming to see us because of fear or because of economic unemployment and things like that. But in the future, the impact of telemedicine and telehealth on the assets will remain those pretty light. And then we have some significant money and big money pouring into the ambulatory from big companies who are either taking this on as an employer or taking this on from an overall community standpoint, that are looking to really redirect traditional patient relationships. And that's been their goal from the beginning as disruptors. But, moving in at this, they always say there's opportunity and chaos. Moving in while healthcare providers are otherwise currently focused on dealing with COVID, how they're penetrating various markets and what they're doing in direct-to-consumer marketing. It's pretty fascinating. It's something that we would definitely want to pay attention to locally. And then lastly, the next slide. A couple of things, increasing prioritization on internal renovations. We're dealing with capacity now, but how do you renovate, how do you improve, and how do you handle all of this moving forward? And then mostly from a financial standpoint, the lengthening out of the scheduling and workflows. We're seeing this with pre-testing on surgeries. We're seeing this with screenings that are happening prior to going to primary and specialty care, all of those things. So it's just lengthening out those workflows and those schedulings and what that looks like. We used to be able to get patients into surgery really quickly, and now we have to COVID test for 48 hours, et cetera. So as we kind of move forward, what does that look like? So I'm going to skip the last, because we've got about 5 or 6 minutes. I'm going to skip the last couple of slides. They'll be included in the program as well as to the decks to the participants. But these are some of the things that we're seeing both locally as we look at the local San Diego market in the southern half of California, as well as what we're also seeing across the board as it relates to our other client bases in the Midwest and in the East Coast and Southwest. So with that, I will turn it back over to Debbie.
Great. Well, thank you very much, Chris, Dr. Sharif, Demetrios, Michelle. That was really informative and timely. So we do have about 15 minutes to address some of your questions. I'll start with the questions that are in the chat box, and I have some others that were submitted to me. So if anybody does think of something they want to submit while I'm going through these, feel free to do that. So, and the panels can open up, you guys can open up your chat box too and see the questions that are posted there, but I'll read them out loud. So the first question is, what are your go-to resources for COVID-19 information? So there are so many varied sources, the public health departments, Johns Hopkins, the New York Times, the CDC. So maybe Demetrios or Mr. Van Gorder, you can kind of share, where do you guys go for your information, your data?
So let me say, and then Chris, feel free to add, a lot of the sites you mentioned are good. I guess it depends on what type of information. If you're looking on data, the state also has some open data sources where you can see by county. The LA Times actually has pretty good data as well. So there's a variety of sources, but the counties as well, just if you're looking for, number of tests, positive cases, et cetera, are a good source, just to give you a quick snippet of what's happening regionally.
Yeah, not much to add. I mean, I would just say that, when we're looking for data, most of what we're getting now is coming from CDC through CDPH, the California Department of Public Health, and ultimately to the county to us. It changes frequently, and that has been a challenge for us as science develops, information develops. Frankly, a lot of adjustments made due to availability of PPE, and then what the CDC would recommend in terms of PPE when you don't have the appropriate supplies. So, but for the general public, I would agree with Demetrios. Yeah, there's a lot of good public sites available right now.
Great, thank you. The next question, I have not heard any seasonal flu numbers, only COVID-19 statistics. Are seasonal flu numbers included in the COVID-19 numbers?
No, absolutely not. No, they're completely separate. It's a separate test, and we can obviously identify influenza from COVID. We don't really have much influenza here right now. We do anticipate during the normal fall, winter that influenza will come up, which is why individuals and expert scientists are predicting potentially a very bad winter when you have a combination of influenza and COVID potentially coming back at the same time.
And just to add to that, so yes, it's not included, but to give you a snippet, County of San Diego actually has a good site through Influenza Watch. Down here, just to give you some sense, those detected through tests are 3-year averages over 12,000 a year. So you start to get some real numbers layered on top of positive COVID cases, and you could run into some significant challenges.
Thank you. So has there been any issues with readmission of COVID-19 patients?
We have, this is Dr. Sharif, we have not seen any readmissions, but we just heard actually just the other day about some of the Navy folks that were on the ship that actually were positive, then negative, and then now positive again. So that's something we are tracking pretty closely as far as recurrences.
Okay. And Dr. Sharif, this next question is for you. I've heard a lot about cytokine storm. Are you seeing that in your COVID patients, and do you have a way of predicting those who might be headed that way?
Yeah, we are seeing some severe inflammatory responses. It's really hard to predict. We see patients who are on the med-surg units, and the next thing we know, they're rapidly deteriorating and intubated in the intensive care units. So it's hard to predict up front, definitely tracking lab parameters and things like that. But as far as treatments go, we actually have had 6 patients total now on ECMO. That's the bypass. And so we're treating patients that way. Early intubation for some of these patients as well. And you may have heard about the COVID convalescent plasma therapy as well, which is a treatment that we're investigating along with others across the country to try and just mediate that inflammatory response.
One of our COVID patients had actually visited New York at the very bad time, came back, was positive, was on ECMO for close to 7 weeks. He is actually off ECMO now and starting to recover. So there is no question that that's a miracle.
Okay, thank you. Healthcare providers say there are a lot of false positives. So how do you determine what is the accurate diagnosis of patients with positive cases or death?
Thankfully, we're not seeing false positives because we're actually testing people who are symptomatic and match the profile. There is some concern now with the Abbott test about false negatives, and that news just came out on Friday from the FDA. The Abbott folks are changing their package insert. We were using that test for asymptomatic patients going to surgery or being admitted, and so now we have to kind of redo that profile and use what's a different platform called the Hologic platform, but we're actually more concerned about the false negatives.
Yeah, you probably saw that the president was using the Abbott point-of-care testing in the White House on a daily basis. That helped us as we got those point-of-care testing across all of our hospitals. It eliminated a lot of our PUI, the persons under investigation. But now that our testing had proved that we had about 89% accuracy, but I guess there's been some across the country that was as low as 80%. And so now what they're suggesting is if you actually get a negative Abbott point-of-care test, that should be repeated with a more in-depth central lab type test. So that means now for us, probably increasing the use of our PPE as emergency cases, cases that you don't have 12 to 24 hours to get a test. We're just going to have to assume they're positive and use full PPE on all of those cases.
Okay. So we know that in the news we've heard we have some recent hopes for a vaccine. So what's your perspective on the vaccine, its time and its effectiveness, given what we're hearing in the news from the CDC?
There's so many different reports out there. My cousin,
right, I know.
He's at Stanford. He goes, "Oh, there's an oral vaccine coming out," which I would love because I hate shots. Chris will tell you about that another day. But as far as that goes, there's a lot of promises out there, but I think it remains to be seen. Most vaccines, as you all know, probably take over a year to develop. We would love if something came out sooner, but hard to tell.
I keep my eye on the company that from out of Oxford that was already working on coronavirus vaccines for the last decade, and they are now in human subject testing because they had an advance on everybody else. Now, whether or not that ultimately pans out to be a good vaccine, I don't think anybody knows yet. But I would agree with Dr. Sharif. I think that the earliest and the absolute earliest would be fall, winter, and very likely into next year before we have anything.
There's also lots of, might as well answer the next question if there's one there about serology testing. There's a lot of questions that we're getting about that. Right now, the tests that we're told are about 80, 85% accurate, and it will tell you whether or not you had COVID. It will not really, we don't know yet what it means as far as immunity goes. Is it 1 month, 6 months, a year? And so what we don't want is this false sense amongst our community that, I've had COVID and I'm protected, because we actually don't know yet what that means.
Okay. Have you seen an aversion to discharging elderly patients to long-term care facilities, given what we've seen during the pandemic or after surgeries?
Oh, yeah.
Huge numbers of that. There's several SNFs and long-term facilities, assisted living, that will not take back a patient who's been positive for COVID until they're cleared twice with 2 negative tests over 24 hours apart. that being said, it's very clear that these tests can remain positive for 20 to 40 days, even after the symptoms are completely resolved. And so that has put a strain on some of our hospitals, especially in the South, who are seeing all the acute cases coming in as well. And so we've actually, worked with Demetrius as well on, what would that trigger be? Unfortunately, we're seeing it more in the South than we are across the county. And so the county has not yet opened up additional SNF facilities, waiting for that magic number. But it's definitely been an issue for us, to the point where some of our home health care workers have not even been allowed in. They asked them up front, have you taken care of a COVID patient? Well, yeah, clearly our staff has, and they have not been permitted to even go inside the SNF to take care of patients. So definitely an issue that we're addressing.
Thank you. Michelle, I think maybe you could answer this one. So a question about telehealth. How quickly do you see this type of platform kind of being the standard of care? And can you just share with folks the impact of telehealth on the volumes that we've seen at some of Catalyst's other patient or other clients?
Sure. So right now, telehealth is evolving, right? So CMS, from a federal standpoint, has opened up sort of the coffers. I think the quote coming out of New York Times is not putting that genie back in the bottle as it relates to what types of providers can be doing telehealth and telemedicine, what the reimbursement, which was key historically on expanding the telehealth platform, and then also what type of applicable diagnoses, what can you use, what can you do with telehealth that you can actually get paid for. So that's expanding. I know the federal government has been looking at it, and in March and April we're very active in pushing out new policies and new regulations and guidelines. I think that's going to continue over the next year as we move forward. So as that continues to become more norm, the standards of care will follow from that. As it relates to the volume, we've done some analysis with some clients that looked at, for every 10% or so that, from a sample, just using MGMA data on productivity and providers. But if you had a 6 to 8 normal physician practice, let's say primary care, either IM, pediatric, or, FM, family medicine, and you were able to transfer of the total practice, about 10% of your patient visits, your normal patient visits, to telehealth or to telemedicine, you could significantly reduce your footprint, meaning that for every 10%, you might be able to reduce one exam room of that facility. So it's going to have significant amount of impact on CapEx, on how we deploy facilities, where we locate them, the geographical reach of our current providers. Now providers can go across states, just like radiologists can. Neuro ICU has been able to leverage across states on ICU platforms. So we're going to continue to see this really impact the care delivery across the platform. But as it relates to how quickly, I think it has everything to do with the financial system. The more that we get paid to do telemedicine, and the easier and consumers command it, the easier this will become standard of care.
Just to add to that, before COVID, we were just starting probably an 18-month roll-up. We put in a fortune in telemedicine, video medicine capabilities, all accessible now via our portal. And now we're averaging somewhere close between 3,000 and 4,000 telemedicine visits a day, and 56% of those are video visits. So we're never going to go back to the way it was. I think the physicians and a lot of the patients have been very, very pleased with the convenience of telemedicine and video visits. So, they're saying that only 2 positives coming out of COVID thus far is no traffic and telemedicine. And I think that's the way it's going to be.
Mm-hmm. There's a question here on the chat that's kind of a follow-up to that, which is just kind of the ratio of telephone-only types of visits versus video.
Yeah, in our case,
what's your experience?
Yeah, in our case, 56% of our visits are video, and the rest are telephone.
Okay. Here's a question. With the difficulty discharging patients to long-term care facility, has the option to designate certain facilities as COVID been explored to alleviate the pressure on hospitals?
I think there were plans to do that, but I don't believe any have been opened as purely COVID. I don't know, Demetrius might be able to answer that one better than me. But
yeah, the whole skilled nursing one was a challenge. It still remains there, and it was something we have had a number of conversations with the county. I think there were preliminary discussions where a couple of facilities said they may be willing to be quote-unquote COVID positive facilities, but I don't think anything more at this point has come of that. I just know there's been a lot of discussions.
Mm-hmm, mm-hmm. And Kristen and Dr. Shi, this is actually a question for me, kind of to that same point. With a lot of the health systems here having multiple hospitals, is it a viable approach to think about consolidating all the potentially future COVID patients in one location?
No.
No.
No. I mean, I think we try to cohort the patients in the individual hospitals, and in our case, because the majority of the cases are coming from the South, we've transferred, I think, 56 patients from the South up to our northern hospitals. But we don't have any enough ICU capacity, frankly, at any one of our hospitals, given the volume we have right now. And so there's really been no serious consideration about creating a quote-unquote COVID hospital.
Okay. This question came into me more, how are the patients that are given the opportunity to, come back in for an elective procedure, how are they responding to that opportunity?
Well, we're not doing any, quote, electives, right, because we're
right.
time critical just based on supplies. And so we haven't opened those up yet as when you talk about electives, but many of them that we have been able, and really it's just been the last 2 weeks. Each healthcare system is struggling with this. I have all the numbers for phases of opening up across the county, but clearly the patients have been waiting a very long time. So those that we are able to get in are extremely grateful for that. They've been very patient, but at some point their patience is going to go away, right? And so we do really need to work closely with Demetrius and team and the county on getting us the supplies that we need so we can start doing these procedures. The patience is only going to last so long.
But you bring up, there's another issue, and that's how do patients, I think maybe is part of the question, do they feel safe coming to the hospitals?
Yeah,
yeah, that has been an issue. I know Ghazala's actually been out on the news multiple times to remind patients that the hospitals are indeed safe. We do cohort our patients, and all of our employees are wearing masks, et cetera, and we're very careful about segregating patients even in the emergency department based upon their symptoms and how they present. So we know for a fact we had one patient, for example, who had chest pains for several days, ultimately came in the hospital in a full arrest and died. And I think their fear was to go to the hospital because of COVID. And so I think a number of hospitals, this is a phenomenon, by the way, nationally, and a number of organizations have gone out to publicly say our hospitals are indeed safe. I don't know if our patients, as we're calling them now and getting their cases, their surgical cases and their procedures scheduled, if they've registered any concern, not that I've heard of yet, but I'm sure that the physician-to-patient conversation helps alleviate that issue.
Okay. There's just one final question I see up here on our chat box, and then I think we're just at about the end of our time. So are we anticipating a second wave later in the year? And if so, what can we do simultaneously to respond?
I don't think we know for sure, but we are certainly planning on surges. I think the concern is that, maybe the hope is that during the summertime, COVID will dip a little bit and act a little bit like influenza. I don't think we know that really will happen. I think it's too prevalent now in our community and in other countries who, people are coming into our country. But I do think there's a concern of a significant surge in the fall coupled with influenza. And we're going to have to prepare for that, and we're already talking about doing that. Again, we have significant surge plans to go 140% beyond our capacity, work in the community to create alternate care sites. UCSD had, put a dorm that has never been open to the public yet, or to students. That was set up and furnished to be an alternate care site if needed. Obviously, we haven't needed that thus far. We hope and pray we don't need that, but those plans are in place for surge if it comes to that.
Well, thank you very much. I see there's some more questions. Unfortunately, we can't get to them right now, but I do want to thank everybody for taking time to join this conversation. It's a very important conversation and one that's changing daily. Mr. Van Gorder, Dr. Sharif, Demetrios, Michelle, thank you for contributing your knowledge today. And if the SOHL leaders would like to say anything, I think we're at the end of our time today. Thank you.